Alright guys, so with this image you can just understand that what topic we're going to discuss today. Alright, this is all the fast food you can see, all the coke and all, everything is there, pizzas, everything, and this is your acidity level in the stomach, and that's increasing gradually. Now you might have seen this kind of patient coming to your OPD. The doctors, they have already searched something on the Google that, doctor, I am having dyspepsia, and somebody is saying that I am having GRD, somebody is saying I am having gastric cancer just because of these symptoms. So in that aspect, it's very, very important for us to know that dyspepsia and GRD, what are these things, all right? So dyspepsia is basically a syndrome or a group of one or more symptoms, and most importantly those symptoms include abdominal or epigastric pain, to be precise, epigastric pain, burning sensation. There should be postprandial fullness, that means after eating patient feel full, and early satiety, that means even after eating small patient feel full. All right, so I'll just write down. So dyspnea is nothing but one or more following symptoms originating from the upper GI tract, very, very important. So there is a epigastric pain, early satiety, postprandial fullness, all right, these are the main thing. And with epigastric pain we also have the burning sensation. All right, yes, so this is what about our dyspepsia. Now when we talk about the dyspepsia can be of two types. First is called as functional dyspepsia, and that's kind of trending, in which we have like no structural cause as such. Whenever you do the endoscopy, several times we do the endoscopy but we don't get any cause, so that's called as functional dyspepsia. You might also refer to some psychiatric illnesses as a functional illness or something like that, but functional, that means there is some physiological issue. In that case, we should not label the patient as a psychiatric thing. That's very, very important. With this you should understand. Now, and talking about the organic, so in organic there is a structural or biochemical abnormality, so in the form of peptic ulcer disease, GRD, even cancers. All right, so functional, when we do the OGD, that's normal. Okay, so as such no structural cause will be there. Okay, no structural cause. Okay, so functional dyspepsia is actually considered, again you can label it in the way of the Rome 4 criteria, with the help of Rome 4 criteria. Okay, so you guys also must remember that Rome 4 is used for irritable bowel syndrome. All right, so they also discuss in that same meeting about the functional dyspepsia. Now what does that mean? Again, as I told you, the definition of the dyspepsia, it should have more than one of these three factors, more than equal to one of these factors. That's what we discussed: epigastric pain, early satiety, okay, and postprandial fullness. Okay, we will see it later also, postprandial fullness. Now in this way, actually majority of the management, yes, pantoprazole helps, but even antidepressants can also be given in such patients. Okay, so that's about the functional dyspepsia, mostly seen in the young females, around 40 commonly, can be seen in males also, but mostly 40s females are quite common presentation for the functional dyspepsia. And organic dyspepsia, as we discussed, there can be structural or biochemical. Okay, so in that we saw two examples: peptic ulcer disease, GERD, and gastric cancers. Okay, so now with this you know that dyspepsia is nothing but a subcomponent or subset that we can see in the acidity of the GERD patient. All right, so we have taken this from the Harrison, no doubt about that. Moving forward to the risk factors. Now this is very important point. As I told you that or functional dyspepsia and the organic causes are quite different, right? So organic causes obviously will be related to the structural diseases, peptic ulcer disease, GERD, all those factors will play a role. Whereas functional dyspepsia again depends mostly in the female, as we discussed. So all those things. Let's see now. Okay, so functional dyspepsia, mostly female, associated with the anxiety and stress. So it's associated, not caused. That's very, very important factor. Okay, so if patient asks that did my anxiety cause dyspepsia, no, you can't say that, right? You have to investigate first, then you will investigate and then you will tell that yes, I can see there is no endoscopic appearance or endoscopic evidences showing that this is organic, therefore it can be functional, then you can label it. So but remember, associated with the anxiety, stress. Now smoking, alcohol, NSAIDs, very very important. Okay, so that NSAIDs can also cause you organic dyspepsia. You guys know peptic ulcer disease, even alcohol use can sometimes cause. Okay, yeah, then poor sleep and irregular meals. So these are some risk factors that can cause the functional dyspepsia. Whereas if your age is around more than 55, that can cause you GI issues. H. pylori infection, very very important. Long-term NSAIDs use, then peptic ulcer, GERD, gastric cancer. These are the examples which we have already discussed. Okay, I hope you understood what are the risk factors for each of the group. Right, now we will see what are the etiological factors with that. Okay, so when we talk about the etiological, again we will divide it into the two group. All right, so when we talk about the etiology, first is your organic causes. In organic causes, again peptic ulcer disease, gastric cancer is there, and when we talk about the functional, we will discuss that. Okay, so let's start with the organic causes. First is your peptic ulcer disease, then GERD, very important. All right, then gastric cancer, especially if age of the person is more than 60 years. Pancreatic or biliary disease, this is also very very important. Okay, in pancreatic and biliary also you can see that, like for example pancreatitis, gallstone, etc etc. Okay, then celiac disease, very important cause for that, and therefore gluten free diet and all is recommended also in patients in dyspepsia. Okay, then NSAIDs use and bisphosphonates. Yes, bisphosphonates are known to cause dyspepsia, very very important side effects, and NSAIDs we all know about that, right? So then we have Rome 4 criteria. As I mentioned, in Rome 4 you should have more than or equal to 1 of postprandial fullness, early satiety, and the epigastric pain or burning sensation. Okay, along with that, remember, in functional causes, in functional as such, there will be no structural causes, and most importantly, so in functional there is a no structural involvement. Okay, but to label the patient as functional, you should have more than equal to 3 days per week episodes of dyspepsia. Okay, these are the episodes of dyspepsia in last 3 months. In last 3 months. Okay, very very important factor. Okay, so more than equal to 3 days per week, and these symptoms altogether should be more than 6 months. Okay, symptoms should be more than equal to 6 months. All right, so I hope you understand with that how important it is to know that Rome 4 criteria to label the patient basically in that category. Okay, now with that we have clinical feature. So clinical feature moreover will be same, in that just few things will be there, that in case of your organic or structural cause, it can be localized. Suppose we have duodenal ulcer, okay, it will be little lower, or if it's gastric ulcer then epigastric. Okay, all those things will be there. So pain pattern will be specific or localized when we talk about the organic dyspepsia, depending on the cause, either ulcer or reflux. Okay, whereas in case of functional, it's non-specific. Patient will tell only that they have bloating, early satiety, and all those things will be there. Okay, then alarm symptoms, if they talk about, moreover it will be present in case of organic dyspepsia, because you guys know gastric cancer, peptic ulcer disease itself, because of that appetite can go down, and it can lead to the alarming signs like weight loss, etc., which we'll discuss in the next slide. Then weight loss, again as we discussed, is common in organic. Onset, as I mentioned earlier also, around young female 40 years, you can see less than 40 years you can see functional, whereas organic is moreover in the elder population more than 55 years. Talking about the vomiting, less common in case of functional and more common, maybe persistent in case of organic. Now nighttime symptoms, again it will be common especially in the cancer people, or maybe even the GERD people. Okay, so I hope you understood with that how to differentiate between functional and the organic dyspepsia. Okay, now we'll discuss quickly about what are the alarming features. All right, when we talk about the alarm features, as such, whenever the age of the person is more than 55 per se, okay, age more than 55 itself is a complication, or aging itself is a complication that can give rise to multiple malignancies, etc., or even your mucosas basically are not of that, don't have that level of the first barrier, right? So because of that they can lead to erosion and further bleeding, etc., GI bleeding. Okay, so second, it's only your GI bleeding itself, Okay, so GI bleeding in the form of either hematemesis or melena, because these are upper GI bleed most of. Okay, hematemesis and melena. Melena means dark stools. Okay, dark stools. So whenever patient comes, okay, I will mention in the history also. That's why we are seeing the clinical features. Whenever patient with dyspepsia comes, make sure you always ask that is there a hematemesis, a blood in vomitus, or if there is any melena, dark colored stool, etc. All these things you have to ask. Now with this very important point, if patient does not know about the bleeding per se, you can just ask for the anemia history. Anemia means you can ask either they get fatigued with simple walking around and all. Initially they were able to perform their activities, but now they are not able to perform, so that's fatigue, right? So if there is fatigue, or you can see the paleness while examining the patient. Now the fourth and important factor would be dysphagia, because esophageal malignancies are very common, and because of this you can see dysphagia also. Now if there is a persistent vomiting sometimes, okay, sometimes because of the pancreatitis or etc other causes, there can be persistent vomiting. Okay, and last is your weight loss. Okay, last is weight loss because of the malignancies. Weight loss because of the malignancies. So obviously you have to suspect the malignancy, that's why we are asking for the weight loss per se, or if there is a history of the malignancy in the family. Okay, yeah, or if there is a history of the malignancy in family. Okay, yes. So after that, obviously we will investigate the patient. We will ask history first of all. That in that also in history, we have to ask for the alarm features, right? So first we ask the history, alarm features. In history per se, you have to ask exactly those criteria is getting fulfilled for the functional dyspepsia, or it is your organic dyspepsia. You have to make sure with the history itself. Now during examination, you are just confirming your findings. Okay, so if alarm features are present or age of person is more than 55, then definitely that's an indication for the upper GI endoscopy. So if patient asks justification for that, then this is the justification, and make sure you refer or write and document it in all the patients, because nowadays you guys know that how the patient are aware about medical legal things and everything. So it's possibility that you might get sued just because you've not written endoscopy, and next few weeks patient gets ulcer. Okay, that's very important. Make sure you categorize the patient and tell them that you should do the endoscopy. So this is very important aspects, that any patient of dyspepsia comes, look for the alarm features which we just discussed. Age more than 55, any signs of anemia, any signs of bleeding, GI bleeding, etc., any signs of malignancies, weight loss, etc. All these things has to be considered. Okay, yeah. So after that, we will see the investigation part. In investigation part per se, I will just start with the CBC itself. Okay, so if you have to evaluate, first we will look for the hemoglobin. Okay, not very important, but more than that, we'll just get the overview of the patient's well-being with that. Okay, then if you can do non-invasive H. pylori test. Okay, non-invasive, because in H. pylori infections also, okay, H. pylori related gastritis also, you can say dyspepsia. So that's also one of the cause. So you have to do the non-invasive H. pylori. Okay, so in that you can do the urease blood test, also called as EUBT, and you can also do the stool antigen for the H. pylori. Okay, so anything, stool antigen for H. pylori, or you can do the urease blood test. Okay, urease blood test not very sensitive, but yes, that's one way to go, right? Then we should look for the CBC. Yes, we are anyway looking for the CBC, right? CBC. Then we are looking for the LFTs to check for the liver function, to check for the pancreatic functions, amylase and lipase. Okay. Next is about the celiac serology. So in celiac serology, we can do anti-TTG IgA antibody, and USG abdomen can be done for gallstone and masses. After that, we will see the treatment. In treatment, first of all, diet is very important. Diet, lifestyle changes, and then treatment we will see quickly. Okay, so let's see. Yeah. So first of all, general measures, what needs to be advised to the patients. Okay. So dietary modification, very important in these patients. All right. In dietary modification, make sure you ask the patient to avoid very small things, but it makes a good impact. Okay. Spicy food they should avoid, because these people are quite fond of this. Okay. Then coffee. Okay. Then alcohol, smoking, carbonated drinks. Okay. So you should, this is quite basic, but you have to document it. Okay, you have to document it, because nowadays it's being very risky. Okay, you have to write this. Then second thing, you have to also tell them that to eat small, and it they can eat frequently if they want, but eat small quantity. Okay, because if they eat excessively in one go itself, that also causes this all postprandial fullness, etc. All those symptoms will be there. Okay, so eat small, and if they want, they can eat frequently also, like 4 to 5 times a day. That's what depends on them, because of the dyspepsia. And most importantly, don't lie down immediately. Yeah. Okay, don't lie down immediately. That's very, very important suggestion that you have to give, because people tend to sleep and maybe eat very late in the day, and because of this there is a high chance of the GERD, etc. The digestion doesn't happen properly. So that's why don't lie down immediately after meal. You have to after meal. So they should go for a brief walk after waiting for 10 to 15 minutes, just after eating, because the till that time the digestion starts. And if you suddenly start walking, the blood circulation, whatever we need and that particular time, might not go as required to the GI system. So maybe some patient may feel indigestion, but it's not given in a literature that it's not like it's absolutely contraindicated that even just after eating you should not go for a walk. Okay, it's not like that, right? Then lifestyle changes. In lifestyle changes, again, as we mentioned, all of this plus if patient is obese. Okay, so some patient may tend to get offended with this, that you have to lose weight. If you tell them that you have to lose weight, they might get offended, like we are already trying and all everything. So in that case, if they're with help of trying everything, and it's even not working for them, then you can look for the modern medicines that are available right now, right? Tirzepatide, etc. Okay, so for obesity, ask them to lose some weight. Okay, and if patient is again GERD, hidden elevation is required, right? And along with that, if constantly stressed or office stress, etc., ask for the yoga, meditation. I barely think any of us do that, but recommended, right? It's given in the literature. That helps. Okay, apart from that, if they are taking any medicines, okay, if there are any offending medicines, for example, let's say any antibiotics per se, you just titrate the antibiotics in that way. Okay, then NSAIDs, yes, NSAIDs very, very important, that can cause this. Then even bisphosphonates, okay, even bisphosphonates, even some iron and theophylline can also cause this, right? So these are the offending drugs that can cause dyspepsia. Now let's see about the functional dyspepsia. In functional dyspepsia, as we discussed, we have the Room 4 criteria, and with the help of that, with in a four-step way, we will see how to manage that. Okay, the first step is always to start the empirical PPI in both of the things, either it's functional or organic. Okay, so we can start either omeprazole 20 mg, or you can start pantoprazole 40 mg. It's common drug, right? Pantoprazole 40 mg. Okay, so has to be started, and for duration of around 4 to 8 weeks. Make sure that patient is getting good amount of calcium, etc. supplements, because we know pantoprazole can reduce the vitamin D, etc. Absorption, calcium absorption, and because of this, patient may get in a longer run, particularly in around more than 8 weeks, can get into osteoporosis also. Okay, so purpose for this, for the to start PPI, is to reduce the acid and the acid related symptoms, because majority of the symptoms are related to the acids, right? So acid reduction is the purpose for the treatment. Then next step, we should add prokinetic. Okay, so while adding the prokinetic per se, our goal is to enhance the gastric emptying and the anti-reflux effect. Okay, so to enhance the gastric emptying, anti-reflux effect, that's how it helps. So we can add domperidone, levosulfide. These are commonly used prokinetics. Okay, so domperidone, you guys know, can give it 10 mg OD. Okay, you can give it 10 mg OD. That has good anti-reflux effect and also causes good gastric emptying. You can give it up to close to OD to TDS also. Okay, make sure you give it before the meals. Okay, that's very, very important. in both the cases, in PPI as well as domperidone, because you will see the best effect in that way only. Okay, now domperidone, then we have levosulpride also, levosulpride, but levosulpride can cause the QT prolongation, right? QTC prolongation can occur. So make sure in cardiac patient we use it safely. Okay, so for that we have 25 to 50 mg OD, but it's contraindicated in the QTC, prolonged QTC patients. Okay, so make sure you monitor that part also. Okay, yes. Then we have etopride. Okay, these are also prokinetic that can help, and we also have mosapride. Okay, etopride. Etopride can be given in the dose of close to 50 mg TDS. Okay, 50 mg TDS. I have seen gastroenterologists giving it because it acts really well. Okay. Also the mosapride, and you can give etopride etc. in case of constipations also. Okay, that can increase the motility a bit, so it's helpful in those patients as well. Okay, so mosapride 5 mg TDS. So these are some of the drugs, and this etopride etc. are the 5-HT4 agonist. Okay, 5-HT4 agonist, thereby they increase the motility, right? Yes. So after that, if still now, even after giving PPI, even after giving motility agent, still the patient symptom persists, then in that case we have to give antidepressant, tricyclic antidepressants that actually you know works against the visceral hypersensitivity and pain. Okay, so it is used for visceral hypersensitivity and the pain modulation, because in either functional dyspepsia or the IBS patient, there is a visceral hypersensitivity. In that way, only antidepressants work well. Okay, so we can give amitriptyline, commonly given actually in the form of either triptomer, okay, really well. So 10 to 25 mg we can give HS. Remember to start slow because sedation can occur with that. Okay, you can also give nortriptyline 10 to 25 mg we can give, that causes less sedation per se. Even mirtazapine can be given. Mirtazapine is moreover preferred if the nausea is also there, because that helps in that way. And mirtazapine basically can help in underweight people. Okay, because it helps in a weight gain. That's very very important benefit of the mirtazapine. Okay, patient gets more appetite and weight gain can occur. Okay, nortriptyline. Nortriptyline can also be given 10 to 25, same way, but it causes less sedation. Okay, and in antidepressants we have mirtazapine also. Actually, this should be all in capital, but sorry for this now. Okay, because as per the guidelines and all everything, we have to write in the generic name and we have to write in the blocks. That's very very important, because if you write in the blocks, there is less chance that look-alike drug mistakes can happen. I hope you remember look-alike. What is that? So look-alike or sound-alike are the two types of drugs. So sometimes drug may look closer or may sound closer to each other, and nurses may be getting confused with that. That's why according to the recent guidelines and all, it is recommended to write in the blocks and in a generic way. Again, that's very important, right? So after that, if patient still doesn't help, so in functional we have to do the cognitive behavioral therapy for them, then gut directed hypnotherapy. Then we have stress management. So in stress management per se, it's especially is given for the anxiety and depressed patient. Okay, and with that we now come to the stage 5. That's the last step. Here we have to give the H. pylori tasting has to be done if patient persistently have the symptoms, and we can give the PCAM regime, right? So your PPI plus amoxicillin. Okay, amoxicillin. If penicillin resistance is there, metronidazole can be given, and clarithromycin. Clarithromycin. Okay. Okay, and for the period of around 14 days has to be given. So in PPI we can give omeprazole 20 mg, pantoprazole 40 mg, doesn't matter. Amoxicillin we can give 1 gram BD. Okay, that comes in that kit only. In that kit, clarithromycin is also 500 mg BD. Okay, yeah, so that's the kit we have to give for the period of 14 days, and after that actually it takes a lot of time for the H. pylori to get back to normal. So it's okay if you don't do the test, but make sure the patient's symptoms are getting better with now. Okay, so that's very important. So Remember, H. pylori actually is commonly not seen, but if it's there, eradication of H. pylori might be beneficial in 10 to 15% of the dyspepsia. Okay, so dyspepsia can get better in 10 to 15% of the patients if H. pylori eradication is done. Okay, H. pylori eradication done. Yes. So these are all important. That's why I'm writing over there. Now coming to the organic dyspepsia management. So in organic dyspepsia management, again it will start with the PPI. In PPI also, we will start with the PPI, our pantoprazole for 4 to 8 weeks. We can give H. pylori. If H. pylori positive is there, that's eradication therapy we can give, and NSAIDs has to be stopped. Okay, so in peptic ulcer disease, the same thing. First PPI we will start. We will see if H. pylori is positive. If H. pylori is positive, we will give the H. pylori therapy. It will discuss in the detail about the peptic ulcer disease, and if patient is having any cause for the peptic ulcer disease, for example NSAIDs, okay, we should stop that. Okay, that should be stopped. Talking about the GERD, in GERD also very important lifestyle. In both of them actually lifestyle is important. Okay, yeah, again in GERD lifestyle per se, just after eating a meal, patient should not lie down. That's very important. Avoid late meals. Plus PPIs, as I already mentioned, and therapy continues actually for longer weeks. Okay, around 4 to 8 weeks. That means close to 2 months we have to give the PPI in these patients. Okay, but make sure if it is recurrent, then maintenance PPI is required. Okay, maintenance PPI is required. Again given as 40 mg daily. Okay, or SOS as required, and surgeries should be recommended if it's recurrent. Okay, and finally if there is a gastric cancer, then in gastric cancer surgery oncology opinion has to be taken, and for that also, okay, yeah, so surgery onco opinion you have to take, and if needed you can operate as per the surgeon's opinion, and but for diagnosis your biopsy is must in this case. That's the basic thing, right? Then talking to the biliary and pancreatic things, in biliary and pancreatic again we have to check exactly for the pancreas function, liver function. So for that we should do the USG. Okay, USG, LFT has to be done, even amylase lipase has to be done. Okay, and lastly about the celiac disease, in celiac disease gluten free diet has to be advised. That should be lifelong. Okay, so basic gluten free diet. All right, so that's all for this discussion. Finally we will talk about the follow-up. So in follow-up we have to reassess every 4 to 8 weeks. Okay, so we have to check for the PPI every 4 to 8 weeks, like this patient need it or no. If needed we can add a prokinetics. Okay, yes, then we have already discussed everything, right? Then if persistent, then in this case psychological intervention has to be done. And if it's still more than 3 months, patient is still having symptoms, then you have to refer the patient to the endoscopy. If there are no, still like if patient is having minimal signs and still the symptoms are persistent for 3 months, then endoscopy has to be advised. All right, so that's all about the dyspepsia, guys. We will meet in the next module of the abdominal pain. If you have any doubts, just let me know. You can either WhatsApp me, or you can, I'll just write both the numbers, 917588 354545. Okay, this is my assistant's number, or you can email me at drgabalevishal@gmail.com. and please subscribe to our channel if you have not yet done. Okay, yes, sorry for this subscribe spelling. Okay, subscribe, yeah, all right, subscribe to our channel please. Okay, now the spelling is also correct, and do comment if you have any questions and share this video. Let's meet tomorrow with a new topic on the symptomatology of that. Thank you.